Okay, so I think we can begin today's Grand Round activity. It will be presented by Dr. Rola Ba-Abbad. She's a valued member of the medical staff here at KKESH, and she's a member of the Vitreoretinal Division and the Ocular Genetics Division as well. Dr. Rola holds a PhD from the University College in London and is a fellow of the Royal College of Physicians and Surgeons in Glasgow since 2011. She's earned a bachelor degree in medicine and surgery from King Saud University, and she has more than 10 years of regional and international experience in medical retina, electrophysiology, inherited retinal disease in countries like the US, Canada, the UK, and obviously the Kingdom of Saudi Arabia. She's practiced her specialty as well in renowned institutions like King Khalid Eye Specialist Hospital, Moorfields Hospital in London, and Sick Kids Hospital in Toronto. She's involved actively as well in research in the mentioned subjects priorly, and she's managed to publish in renowned journals. She's also a member of the Association for Research in Vision and Ophthalmology, and is a recipient of the Diana Davis Spencer Clinical Research Fellowship Award from the Foundation for Fighting Blindness in 2018. Today she will enlighten us and help us understand about the variant classification from the American College of Medical Genetics and Genomics, and hopefully help us understand the importance of these variations, which are the backbone of genetic research, counseling, and providing medical treatment for these patients. So I'll give the floor to Dr. Rola.
Thank you very much. Can you hear me over there? Okay. So I'll try to keep it dynamic because it's post-lunch and I think everyone is about to fall asleep, so I'll try to stay awake. So thank you very much, Dr. Samedi. So basically, I'm grateful that Dr. Altaf has introduced the audience to the basics of genetics. And the reason that I'm talking about this particular subject is that there is a move towards democratization of genetic testing, which can be organized either by the treating physician or even by genetic counselors. So ordering the test is easy, but then dealing with the consequences and the outcome of the test and dealing with the family later on is the challenging part. And the responsibility does not only fall onto the shoulders of the lab or the molecular geneticist who produce the report, but also on the clinician who's going to relay the results to the family and the counselor, genetic counselor. So we're going to just quickly skim over genetic variations, the type of genetic variations, and then we're going to introduce only the guidelines, but then feel free to email me and then I can send you the full PDF to read through because it's quite a rich paper. And then we can touch upon the importance and clinical implications of variant interpretation. So just to brighten things up, I mean, these are all, my beloved parrot actually comes from this species, and they're all called lorikeets and lories. So basically they are genetically quite similar, despite that they appear different. So variation is the essence of biology, and we are different from each other because we do have genetic variations. And that doesn't mean that these genetic variants are disease-causing. Okay, so the genotypic variations are caused by differences either in the number of or structure of chromosomes or by differences in the genes carried by the chromosomes. Okay, so that's a simple, straightforward introduction. And now we can move on to something that we call the loss of function variants. So why do we focus on loss of function variants? This sounds quite alarming, and you think like any loss of function variant is likely to be disease-causing. And when we go over this, we're going to show you that there are always exceptions to this. And the interpretation can be misinterpreted by either the clinical geneticist who reports the variant or by the clinician who's not familiar with the gene itself. So the gene starts with an initiation codon, which is basically ATG, the nucleotides, or it encodes for the methionine. And then you have a final stop codon. And this is how the machinery inside the cell will recognize this is the beginning where the messenger RNA is being produced, and this is where I should stop. Okay? There are also areas, flanking areas, like the promoter, for example, and you have also the poly A tail at the end of the gene, and you have the untranslated regions. Okay? Some even of the exons, say for example, a classic example is in BEST1. The first exon is not translated. And therefore, if you happen to sequence a patient with autosomal recessive bestrophinopathy, for example, and you find only one change and you don't find the other, then probably the lab did not even enrich the panel for the first untranslated exon, and they might have actually missed that. And this accounts for missing heritability in some genes that are known for having this feature. So as a clinician, unless you are familiar with the gene and the structure of the gene, at least to a certain degree, you might be missing quite a lot, and the also clinical geneticist who's not familiar with that particular gene may not even know it. So that's, so then we go into one of the loss of function variations, which is the start loss. Basically, the ATG is no longer there. Okay. Now, you might, superficially say, okay, the ATG variant or not variant, sorry, the ATG code is not there. It means that the entire copy of this gene is deleted. And that's not always the case, because there might be another start codon somewhere in the gene that the machinery can just start from, and the protein will be fine. So again, not being familiar with this, not being familiar with the gene itself, and knowing that there are different start codons actually might give you completely wrong interpretation, and I have clinical examples of that. Missed by the lab and misinterpreted by the clinician. Okay, so that's one thing. This stop is a stop, so the stop should come at the end of the gene, right? But then if it's a premature stop, then you'd think that the protein, if it is translated, it will be truncated. It will be missing some amino acids. Is this always disease-causing? The answer is, again, no. Okay, and I'm not going to waste your time, otherwise I will be speaking until tomorrow about examples of why it's not always the case. And then you have the frame shift. So if we are reading the frames in 3 nucleotides at a time, then any addition or deletion of a number of nucleotides that's not divisible by 3, like 1, 2, 4, for example, then it will create a new frame, and that's why we call it a shift. Okay? This new frame for reading will include abnormal amino acids, because now the entire code is different, and it will eventually end up in a premature stop as well. Okay. Now, moving from the small bits to slightly larger bits, which is the copy number variants, now we're not talking about 1 or 2 nucleotides, we're talking about a chunk. Say, for example, hundreds, okay? And this can be inserted, or can be deleted, or can be even like a combination, like what we call an indel, or it can be even an inversion in addition to one of these additions or deletions. So all of these can also interfere with the function of the gene, and it will eventually lead to loss of function. Okay. Now, moving to another mechanism, which is now you have the DNA being translated to, transcribed into mRNA, and then what does the cell do? Basically, it reads the code, and then how does it know that this is the beginning of the exon and the end of the exon? And how does it chop off the intron, because it doesn't use it for coding? There are certain what we call canonical splice site codes that actually tell the machinery that you should stop here and start there. Anything that messes with these codes also ends up with loss of function, okay? Or exon skipping, for example. Okay, and then there is something that is quite rare in the ophthalmology world, at least, the stop loss. Now, we're supposed to have a stop signal at the end of the street, right? But then if you just break it. So again, the amino acid or the protein will be, the length of the protein will be altered, and this can create a toxic protein for the cell. So that's another, so it's not always shortening that, shortening or truncation of the protein. It's also like making a longer than normal protein can actually interfere with its function. Okay. Now, I think Dr. Altaf has covered already the missense changes. We talked about the large in-frame. Now we spoke about the frame shifting changes, which can be small or can be large. But also you have changes in the length of the protein that are in frame, still divisible by 3. Okay, no matter how big, you can even insert like 300 nucleotides, and that's still an in frame. Now, is it always disease-causing or pathogenic? Well, it depends on the gene, actually, and depends also where did this deletion or insertion happened. So say, for example, and this, actually, I want you to pay attention to this because this is going to come handy in a clinical example that I'm going to show later on. So basically, there are repetitive regions in some genes that even truncating these repetitive regions to a certain extent may not affect the function. So maybe, like, you add a few, in-frame, nucleotides, and still the cell can go on without any problems, or you can even delete it. Okay? So again, people might be alarmed. Okay, this is a deletion. This must be like disease-causing, and they even publish cases about that, and it's not the case. You need always to have a backup, and the guidelines are basically about collecting evidence. Okay. All right. So we talked about upstream, downstream of the gene, or in the promoter region. Synonymous changes are important also because they can fall into a splice region despite that they don't encode for a different amino acid. Some amino acids can be encoded by several combinations of nucleotides. So some of these changes can happen at the edge of the exon and therefore can interfere with splicing without interfering with the protein they encode for, and they still can cause disease. So not all synonymous changes are benign. Okay, and one of the examples, I haven't seen it yet in Saudi Arabia, but I think we might come across those patients at some point, is the multiple repeats or the repeated sequence. And one example of this is the spinocerebellar ataxia, which can also present with cone dystrophy and maculopathy. Okay, any questions? So why I'm bothering you and putting you to sleep, and what are these guidelines all about? So if you have different labs reporting in different style and everyone giving different opinions without really relying on the same evidence, then you end up with, kind of bowl of salad, basically, of variants that you don't know really which one to report to the patient and which lab to believe. So there must be some sort of consistency across all the labs to get the accreditation and to have meaningful reports to produce. Okay, and then if you have the report and if they follow the guidelines, then you know as a clinician which variants are actionable that you can phase in to find out if they are in cis or in trans in the parents, for example, segregate with the affected or the unaffected family members, provide pre-implantation diagnosis and family screening and treatment eventually. But without actually knowing which ones are actionable, you're in the dark. And you go right, left, and center, and you do all of these things, and you misinform the patient and misinform the family. And this can have implications for generations to come. And which variants are also should be noted in the report, but not considered for future action. That's also important. And which variants can be safely ignored. So this is the wisdom of interpreting the report. Okay, oops. So why I'm talking about all of this, this is an example of our raw data for a patient. And you can see here, this is a patient who does have 23, okay, so 231,000 variants, okay, in all the somatic chromosomes and the X chromosome. So imagine if you don't know how to, as a lab, you don't know how to sift through all of these variants and which ones to report. And if you pick the wrong ones and they inform the clinician, what would happen to the patient and the family? It's a serious business, okay? So this is a busy slide, but basically what we talked about early on is the basis of labeling or classifying the variants into 5 classes. Pathogenic, likely pathogenic, variants of uncertain significance, which is the headache forever, and then you have the benign and likely benign. And surprising enough, actually, you have to have evidence to classify a variant as benign. So it's not something like as straightforward. There are also criteria for classifying a variant. So in the case of pathogenic and likely pathogenic, you know, the case is relatively easy. But again, it depends on your knowledge of the gene and the mode of transmission. So some loss of function variants in dominant genes, for example, are not disease-causing because the mechanism for disease in these dominant disorders is gain of function or even missense changes that interfere with the normal copy of the gene. So haploinsufficiency, which is basically 50% of the protein is present, is not always disease-causing in patients with dominant disorders. So even if a variant is being classified as loss of function or even pathogenic, that doesn't mean that in that particular context it is pathogenic. And you shouldn't be like chasing the rest of the family and trying to segregate it and spend money and waste time on nothing. But then, as you can see, to classify a variant as pathogenic, you have to have very strong evidence that you collect the criteria. And these criteria are quite stringent, and they are even getting more stringent. So this is the 2015 guidelines. They're about to publish the update, hopefully soon. But also the UK system has produced already strict guidelines, which can even, they call it hot or cold, even among the variants that are classified as VOSs. So it's really serious business there. And then for the evidence of pathogenicity, you can see that you have to, even when you consider null variants, which is loss of function variants, you have to be aware of genes where loss of function is not a non-disease mechanism, as I just mentioned. And you have to be aware of all of these caveats to be able to counsel the family, because the serious implications include even termination of pregnancy. Imagine if you terminate pregnancy based on wrong information, which is, God forbid, hopefully doesn't happen. But it is that serious if even it's escapes the scrutiny even of the PGD doctor and the people on the other side of your practice. Okay, even to classify variants as benign, you have to apply these criteria, which is the lab hopefully does for you. But you have to be aware that these criteria have they been actually applied or not. And this is how you can even sign a contract with the lab or not. You check their reports and see what they are reporting. Okay, so a good example of a report is, say, for example, the lab is reporting to you this particular variant, and even the transcript is mentioned. So they use something that we call the canonical transcript, which is the longest one, because some genes do have different transcripts that contain different exons. So there might be something that's not even relevant to your patient. For example, gene that causes X-linked retinitis pigmentosa is called RPGR, and it's a common one, and we have patients here. The retinal transcript has 15 exons, and exon number 15 is basically a modified intron from the longer transcript that is not even expressed in the eye, which has 19 exons. So if you have a variant in, say, for example, exon 17 in RPGR, then you don't call the patient having X-linked RP. Okay? So you have to mention, or the lab has to mention the transcript from which they annotated the variant they found, the location, the variant itself, and then the zygosity, and then the classification. But not only this, they give you justification for why they classified. if the lab doesn't justify their classification, you have to put a big question mark about what they're doing. Okay? And one of the things that, the caveats that you should be looking for is classification based on in silico predictions, which is basically computer algorithms that look at the conservation of the variant across species, humans and versus non-humans, primates, and then all the way down to rodents and even sometimes fish, like zebrafish, for example. And there are some statistical methods to calculate the likelihood of having this variant in the population without causing any trouble. So most of these algorithms are only artificial, and they have little, if any, backing from biology, except in few cases where actually the algorithm picked up the variant that is actually deleterious, and in practical it's actually still deleterious. Say, for example, a variant in gene called OAT, which causes gyrate atrophy. And despite that the variant is a missense change and it hasn't been tested before, and it's correctly labeled as a variant of uncertain significance, but then the patient has the clinical features of gyrate atrophy, and you test for serum ornithine level and it's sky high. So then you have some sort of biochemical evidence that this is likely to be the cause of the disease. No matter how many algorithms that the lab uses, it can be 10 or 20, still it's only supporting evidence and shouldn't be taken as evidence of pathogenicity on its own, unless you have other pieces of evidence to add up with. And therefore, if the lab writes, in silico prediction predicts deleterious, say, so what? Okay. Now, this is basically how you apply the criteria, and then you can move in the spectrum from strong, supporting for benign, to supporting, moderate, and strong, and very strong. And then you add this up to actually come up with the final classification of the variant. Now, because you're clinicians and I'm a clinician, then we can move to the serious stuff, which actually related to the patients, because all of this is theory until you apply it. So this is a patient I've seen, 13-year-old female with retinitis pigmentosa, as you can see. Mother has got also retinitis pigmentosa. And for a young teenager, this is considered to be severe retinitis pigmentosa. Okay. Then this is what the lab came up with. So basically, this kid was tested, and then she was found to have the PRPF31 variant. I'm putting it in red color because it is a known pathogenic variant in this gene. And PRPF31 causes autosomal dominant retinitis pigmentosa, but there is a catch there because it has variable penetrance. So somebody might have exactly the same variant and not have RP, which is totally acceptable. But in addition to this, because the lab was so diligent, reported with equal weight the two variants in EYS. And then, they sent the clinician in a goose chase because now the lab suggested that these variants in EYS, and they completely ignored PRPF31, and suggested that these variants in EYS to be segregated in the family, and it became even more confusing. Now, the father is carrying this variant, which is a variant of uncertain significance. The mother carries this variant in addition to another one, okay, which you don't know even whether they are on the same copy of the gene or on different copies of the gene. And then, even to make matters much worse, the younger brother is being tested, and they have been found to have like 3 variants. And the clinician was at loss, so the clinician told the family, okay, your younger son have a chance of developing RP, but we don't know when. Now we are dealing with like a very sad story of severe RP, and now somebody who's completely normal has been tested, and bad news has been delivered. Based on what? Segregating variants of uncertain significance in the family. While if you concentrate on the pathogenic variant, you would find that actually the mother is carrying that too. And all of these variants are actually noise. Despite that EYS causes retinitis pigmentosa, so you might just say, oh, okay, it might be like severe, retinitis pigmentosa because the kid has got like, 2 genes, variants in 2 genes, and maybe the mother too, which doesn't make any sense. Because if it made sense, actually, these are on the same copy of the gene, so the other variant, supposed variant that causes EYS-related autosomal recessive RP is missing in the mom. But you missed the obvious. So this business can go to bed, but at least maybe, 21,000 riyals have been spent on this family for nothing. Because also the clinician forgot that EYS is usually, and there are always exceptions, usually an adult onset retinitis pigmentosa. So having a kid with this doesn't make sense. And having a normal kid with these 3 variants doesn't make sense either. But again, overlooking the classification and adding the weight and looking at the evidence and what we know about these genes have made a huge mess with the family. So that's the first example. Let's give you a quick tour over a gene that I don't particularly like, but it's called RP-like. Okay, so RP1-like protein 1. So what you can extract from this term is that it is similar to RP1, but it's not quite the same. Okay, and what are the disorders associated with this? Occult macular dystrophy, so-called Miyake disease, which is a dominant disorder. And this dominant disorder is associated with certain missense changes in the gene in certain domains. So not everywhere in the gene is going to cause occult macular dystrophy. And this has to be borne in mind because the lab can't just say, okay, this is a novel variant. This has not been found in the population database. Okay, this is the cause of, and the patient has got completely different phenotype. So if the phenotype doesn't fit, then you should scratch your head and think about, okay, there might be something else. Now, more recently, retinitis pigmentosa, autosomal recessive, have been associated with biallelic variants in this gene. But in all the cases, all those patients presented with adult onset RP. It's never been reported in kids. Okay? Now I have this young lad, 11-year-old, coming to my clinic. And since infancy, he had symptoms. And he wore myopic astigmatism correction at the age of 2 years. And he is both photophobic, and also he's got also symptoms under dim light. And he's got better visual function, but he started lately bumping into objects. His color vision is reasonable still, and his visual acuity is still good. And looking at the family pedigree, you can see that it's heavily consanguineous. And your brain automatically tells you, oh, it's autosomal recessive. But that's not always the case. The problem is that, Okay. These are the color fundus images. As you can see, he's got vascular attenuation. There is little left in the retina here in terms of the ellipsoid zone, little bit of cystoid macular changes. But then you can appreciate that the RP is quite advanced for an 11-year-old. And that's what the autofluorescence looks like. So you have, again, to summarize, we have an 11-year-old boy, very early onset retinopathy with myopic astigmatism and history of consanguinity. So the initial molecular diagnosis on referral came with the notes of the child, and it showed that he is homozygous for what the lab called clinically relevant variant in RP1L1 with significant phenotypic overlap. And then they put this like horrible long insertion there, and they went to the length of testing the parents, and they're both heterozygous, obviously, because he's homozygous. And they also tested the unaffected brother, and he was found to have wild-type alleles. Case solved, right? Okay. And then a different variant has been published from the same center that referred the kid. And instead of this, short insertion, which causes a frame shift, a much longer insertion was reported for the same child. And now it's another frame shift. Okay? Number one, the insertion is not a frame shift. It's divisible by 3, and it equals 16, so it's an insertion, it's an in-frame insertion. And the second question is, where is it exactly in the gene? So basically, the same insertion that was reported in the research report is actually part of this larger insertion, which is not a frame shift, it's an in-frame. Then, okay, here's another mistake that happened. But that's not a huge mistake, isn't it? Just like counting numbers. Now, if you check population database, for the same frame shift at different locations, you will find, if you look here at this column, the number of homozygotes, one of these frame shifts is found in more than 6,000, almost 7,000 people with no retinitis pigmentosa. Okay, there is something wrong there. Because it can't be all of these people don't have retinitis pigmentosa, and then this poor kid has got. Okay? So you examine mom. Now the mother is myopic, and then you question, it's not only myopic changes that you see, because it's highly unusual for a myopic lady to have lens surgery at the age of 30. There's something wrong. Okay? And when you see here, you see the changes and also the distribution of these changes. One, helpful point is that you can see the radial distribution of the autofluorescence changes. And this can point you towards something. The mother didn't complain of nyctalopia or anything. She thinks she's normal. She was told, you're only myopic. And obviously, you can see that she's not only myopic, she's got pigmentation, she's got loss of the RPE, and these are the scars from the previous laser retinopexy. And the shadowing here is just the edges of the YAG capsulotomy in both eyes. And this is her OCT. She's only left with this. So we resorted to, I told the family, look, what you had was basically a research grade genetic testing, which was based on homozygosity mapping. Homozygosity mapping is a technique that the lab uses when you have a heavily consanguineous family like this. And it has been used successfully in King Faisal Specialist Hospital, and it resulted in so many genetic discoveries, and it's wonderful. But it can be misleading, because not every consanguineous family has recessive disorder. So what the lab did was basically overlooking everything, but just looking for the homozygous regions in the genome of the kid. And this is where things got completely wrong. And the kid has got X-linked retinitis pigmentosa. So when we did clinical whole exome sequencing, we found that the kid is hemizygous, because he's a boy, for a frame shifting variant in RPGR, which is under clinical trials. And this particular variant has been published twice in association with disease. So what's the take-home message? Number one, not being familiar with RP1L1 and knowing that actually the end of this gene is actually less conserved, and it's highly variable even in normal people. And then, to add to this, in the discovery paper for RP1L1, which I'm quoting here, they found that 48 base pair polymorphic coding repeats have been found in normal subjects up to 6 times. And this has been completely overlooked by the lab because they are not familiar with RP1L1. And the second thing is that loss of function, even if you agree for the sake of argument that this is a loss of function frame shifting variant, loss of function variants in the last exon of any gene don't usually cause truncation of the protein to the extent of subjecting it to nonsense-mediated decay, which is like a protective mechanism by the cell to get rid of any mRNA that is dysfunctional. So they are not subjected to this because it's far at the end of the gene. It doesn't cause much trouble as far as the cell is concerned. And then the other clue that the clinician should have paid attention to is that RP1L1 associated RP is an adult onset, not pediatric onset. And obviously missing the mother and missing all these signs in the mother was also something that should have been paid attention to. So if we go back to the pedigree once more, now you can see the mother told me that her eldest daughter has got a son and her 5-year-old grandson has got nyctalopia. If gene therapy becomes available and this family has been miscounseled and misdiagnosed, probably for generations nobody is going to ever receive treatment if treatment becomes available. So that's my second case. Just the last case I'm going to also share with you is a case that was, I'm grateful that the clinicians here were able to pick it up despite the previous impression that this kid might have KCNV2 retinopathy, which is not the case. Because what I wanted to show you instead was what difficult to interpret lab report looks like. So this is the same kid who was suspected of having cone rod dystrophy, probably because of KCNV2 mutations. This kid has undergone next generation sequencing panel for cone rod dystrophy. And it depends on the year where the child was tested. The panel may or may not contain the genes in interest. And now this is 6,000 reals, spent. So let's look at how confusing the lab report was. If you just look at this, the kid does not carry putatively pathogenic mutations in any of the analyzed cone rod dystrophy, but then they did the courtesy of extending the screening. And then they found 2 heterozygous variants in a gene called MKS1, which causes some sort of a variant of BBS, which is called Meckel's-Gruber syndrome. And now we have things that are not related really to what the child has, because the child developed total RD. And then the other eye developed also lens dislocation and then cataract, and then the diagnosis was clinically revised to possible no-block syndrome, despite that the kid didn't have the typical features. But it's just a high myopic eye, retinal detachment, cone rod dystrophy. And the clinicians were right. And they were right in ignoring what this report showed. Because when this child was actually diagnosed and then the clinical suspicion of no-block syndrome was raised, then the kid actually showed the real variant. And then the lab actually did the courtesy of actually saying, like, we found all of these variants that the previous lab found, but we did not even report them because they are completely irrelevant. So unless, as a clinician, you use your own judgment, you might just copy and paste what the lab says without really knowing what the patient has. So this is the end of my talk today. I hope that it was of benefit to you, and thank you very much for your attention.
Thank you. Thank you, Dr. Rola. Do we have any questions for Dr. Rola right now? Anyone? Okay, I have a question. So from a practical point of view, in your very last case, I was thinking about it throughout your presentation, the very last case, I know that when we order genetic testing, we have to provide a clinical picture to the lab. Is this why it is so important to describe everything that you're finding and not just say cone rod dystrophy, because it will lead the lab to a misdiagnosis?
you need to narrow down the diagnosis as much as possible through phenotyping. Sometimes it's difficult because all what you have is just retinitis pigmentosa, but then the age at onset, the family history, even you should be, dilating the parents if necessary and examining them properly. Adding also to this, your familiarity with also certain features, say for example, abnormal teeth, for example, in the case of Jalili syndrome, or history of hearing loss, which can be associated with the retinopathy and sometimes can be completely separate. And you can have different families, segregating RP in one individual and hearing loss in another, and then somebody got unlucky and kind of had the combination. So even expanding your phenotyping to the other family members can guide you to find out what's going on. The more you ask also about, renal failure, one issue here is that we have most of the female patients, they come to you and they never, unveil, their faces. And then, you miss quite a lot of syndromic features like that. Sometimes even the family member talks on their behalf. And if you just start listening to them, you will immediately notice that they say assalamu alaikum, which means like they've got like some sort of hearing loss, which is not severe enough to make them deaf mute, but they missed all the high frequencies. So that guides you to Usher syndrome. So you have to speak to them, ask them about what they like, about how far they got in school. And it can tell you, if they speak to you with like childlike, attitude, you might think of BBS. BBS is not always obese. You know why? Because some of them now have undergone bariatric surgery. And you might miss it completely. Not everyone has got polydactyly.
So that's the importance of a good clinical exam, but also copying this on the request for the genetic testing.
Because what the lab does is to match this. It's not magic. So what they do is that they match your clinical history and examination into something that they call HPO terms, Human Phenotype Ontology. And these HPO terms will will narrow down the possible genes associated with these features. The more HPO terms, the narrower your search and the search of the molecular geneticists also in the lab.
Yeah. Now, to understand the 5 classifications of the variants, how did the labs come to this consensus? Was it by reports that were previously made, obviously by research that has been previously published, and that's when they say this variant we will classify it as pathogenic or benign or in between?
So it depends on the type of the variant, depend on the level of evidence associated. Say, for example, one of the evidence associated is basically that this particular variant has been reported in various populations of different ethnic background or different families that presented with the same phenotype. There are also variants that have been tested biologically. There are also variants that you can test in the lab, say, for example, the serum ornithine, and there are other examples like Sanfilippo associated HGS-NAT. They can present also with non-syndromic retinitis pigmentosa, and if you test for the enzyme, you will find that the enzyme is dysfunctional. So you aggregate the evidence, and therefore new variants are mostly, classified as variants of uncertain significance until proven otherwise. Say, for example, even association with a certain, say, for example, phenotype. In the Saudi population, it's an endogamous population, and not only consanguinity, but also the entire population did not really have intermarriages with other ethnic groups in general. So what you have is founder mutations that you can find in people coming from the northern part of Saudi as well as the southern part of Saudi. And if you even search the Khaliji literature from the Gulf states, you will find some of them are also sharing the same founder allele. Now, these founder alleles can be disease-causing, but also, because of that, founder variations, I would say like a pathological variation, can be very prevalent in the population.
So that leads me to another question. When a genetic lab is using their database to classify the variants, is this which databases contribute to that? Is it do we have a local database that feeds that, or it only takes into account certain? So
it depends on
countries?
how. Okay, in our case, it's a bit tricky because say population-based databases like Nomad and others. Just recently in version 4, they added the Middle Eastern genomes. In the past, there weren't. So we are a blind spot to them. But the labs that have been in the Gulf region, and they use this as to their advantage, obviously, and they've sequenced thousands of patients without sharing the data with anybody, they do have their in-house databases. And then against which they can compare. If they've received this particular variant from another patient, say comes from a different region of the kingdom with the same phenotype, then they would say, okay, it's a match. So this is something that they earn money, obviously, because.
Yeah, Dr. Rubio, there's.
Regarding your last topic here, so who owns the genetic information of the patients we send the testing for? The company, or we know this information?
We now own it. Previously, we didn't. Not because we didn't have the right to, because we didn't have the means to store it. But now we've established already that we have the right to acquire all the raw data, and then we can save it in our database, and we are working together with Dr.
So basically, a genetic lab will offer you the service of storing the data for you, which means that basically they keep it. You do not have access to it. But
yeah, but the thing is, I think it's super interesting to hold the data for yourself, because if the next case you have the whole
this is what we're doing now.
That's what we're working on, and that brings me to another question. What are the ethical implications in the entire interpretation? So you order a test, you receive it?
Yes.
What can you give some examples of ethical concerns?
One example is incidental findings. So the incidental findings depend on whether the patient wants to know or not, and then they have to consent for it. If they consent, then you are obligated, if there are incidental findings that are actionable, and they are currently internationally known 73 genes, including genes that are associated with cardiomyopathy, associated with hereditary cancer syndrome, and so on. So you are obligated, if the patient consents, to inform them and counsel them and take action. If the patient does not consent, then you're not allowed to. Even the example in the 100,000 Genomes project in England, the patient specifically recruited, say, for example, at one of the centers, they were told that even if we find that you have a BRCA1 gene, we're not going to tell you, and you have to consent that we're not going to tell you, withhold the information from you, because this is not the scope of testing at this stage. Because the patient might sue the hospital later on and say, okay, I mean, why you didn't tell me? Well, it's part of your consent. So that's one thing that, so you don't, if they don't consent, I even test families, I don't even test families like blood-wise, but I examine them, I dilate the fundus and look at the eye just for the sake of diagnosing another family member, and I ask them, do you want to know what I've seen? And if they say yes, I will tell them. If they say no, I will just hold my peace. I will not talk to them. Another ethical dilemma is the pre-implantation diagnosis. So it's clear-cut in disorders that are, that have severe implications, like metabolic disorders, like, lethal disorders, like Batten's disease, and so on. And if the variant is already classified as a pathogenic variant, then the family can take this further, either to go for pre-implantation diagnosis or even to choose to terminate the pregnancy if they have the legal authorization to do so. Now, you have sometimes disorders that are not blinding. Say, for example, congenital stationary eye blindness. It can be sometimes severely disabling with nystagmus and high myopia, and patients can have really difficult life. But if the family comes to me and say, okay, I want you to refer me for PGD, or I will just say, okay, just send the request, and then I will raise it to the ethics committee at the hospital. We'll discuss, this is not a blinding disease, and then we'll get back to you. So, you try not to take the decision unilaterally. Another example is the variants of uncertain significance in RPE65. Now, there is a paper in the literature where the patient, if I remember correctly, had variants in another gene, I think one of the nephronophthisis genes, if I recall correctly, as well as RPE65. And you can see in the clinical paper, the retinal images show clear autofluorescence signal there in the retina. And for some reason, I can't really speak on behalf of the authors, they went ahead and they did gene therapy. And the patient developed some inflammation, and obviously there was no improvement whatsoever. So again, if you are not sure, if it's a variant of uncertain significance, you have to call for something that's called multidisciplinary team meeting that contains not only specialists in your group, but also molecular geneticists and other international members. And then you can take the consensus whether to go ahead or not. Because you might harm people, thinking that you're going to help them. Not all RP65 variants are pathogenic. And therefore, when I met one of my colleagues in Japan, they said we're not allowed to. So VOSs and RP65 are not with an MDT, without MDT. In England, they are more lenient towards MDT meeting because it has like a consensus from different scientists. But in Japan, it's not approved.
Thank you. Any other questions from the audience?
I have another one.
Yeah.
So, I find this super interesting. For instance, is that possible when you begin to accumulate the whole genome sequence here for any patients? Well, in another side, you're going to store also, which is the keywords for characteristics. For instance, you will have, let's see, planning in the future, like 1,000 genomic, and you classify also as an ictalopia. Is that possible when you go to search for these genomes to be able to understand if there's some of the variants you say this is not pathogenic or maybe suspicious pathogenic here, you can be able to ascertain if there's a value as a pathogenic or not?
To a certain degree, you can. Say, for example, like the example of the PRPF31. I can assign less weight now to the EYS variants. And I can add it to my database that there is another explanation, another gene that explains the phenotype fully, and the others are just noise. So if I happen to come across another patient with, with these particular EYS variants, I might think like, I need to think again, and probably the patient has got something else. So by accumulation of the data, and also if you happen to, say, for example, have somebody with achromatopsia, and then the patient has got also and the clear phenotype of achromatopsia. There is no doubt about rod function or whatsoever. There is no, issue with retinitis pigmentosa. And then the lab, throws at you a couple of variants in other RP genes. Then you can easily just discard them, and once you see them in another patient, you know that it has no effect whatsoever. And then with aggregation of the data, then you will find that, say, for example, in your database of 100 exomes or genomes, this variant has been recurrent in, say, 5 subjects without having the phenotype, or several homozygotes without having any issue. Then it's just a private variant to this particular population that it has no bearing whatsoever. And there is something else that is called linkage disequilibrium. So what happens is that even if you segregate, so segregation is not a magic word. Even if this particular variant segregates in different family members, say, for example, in a highly consanguineous family like this, a first cousin is not really that distant because they share quite a lot of the same haplotype. So when you say it segregates, it could be in linkage disequilibrium, which means that it's just tailing something else that you haven't discovered yet. So rushing to publish this as the disease-causing variant is actually quite misleading for the population that you are dealing with, and also the international community that are going to refer to your paper and cite your paper, and you might even end up with quite a lot of few families misdiagnosed because of this.
Great, thank you. Yeah, Dr. Khan.
Thank you, Dr. Rola. I have a question regarding the workflow here at Kekish. So the first question, how common do we do genetic testing? And the second question, if I have a patient and that I would like to have some genetic testing to be done for that patient, what should I do?
Okay, Dr. Semedi, I think he's the chief of division.
No, but you can answer that. So ideally, we need to understand that not everyone because of the ethical implications and the examples that she's given, not everyone should be ordering genetic testing. You said it at the beginning, genetic testing is easy, yeah, making the order. But developing the clinical profile, examining the patient systemically, this is something that we as ophthalmologists don't have much experience doing. So ideally, these patients need to be referred to the genetic clinic and the testing to be ordered from there, unless it's a known congenital glaucoma case or something that you're just ruling out. We have the genetic clinic. Dr. Sausan, Dr. Abrar, and Dr. Rola are doing the clinics, and they can gladly assist you with that. But you need to refer the patients through them.
So if I have a patient, like let's say today in my clinic I saw a patient, let's say some sort of anterior segment dysgenesis, and the family, they were asking, is this something like genetic related or just sporadic? And I want to prove that. Should I call whom? Is there on call? Is there? Should I just request request?
On call, because we have the habit of calling the on call for appointments, and that beats the purpose, right? On call is for emergency, and they have.
I totally agree. So if I just request appointment, is that accepted?
Absolutely, yes, absolutely.
Okay.
Gladly assist the patient, and if there is a novel finding, don't worry, we're not going to publish it without you.
Yeah. Either way, you could also email one of the physicians, and they'll be glad to help you with the appointment as well. Dr. Abrar, Dr. Sausan, and Dr. Rola. All right. Any other? Yeah.
First, I want to thank you very much for your. No, it's simple. I'm a simple person. I want to thank you, and I would like to know what is your strategy when you have genetic tests that don't really, that are confusing, that don't fit. Where do you go, and where do you discard a mutation or a variant from being, that is just noise, from a mutation that is, probably disease causing? What is the strategy? Where do you go for the database? Do you, what are the sites that you consult, and what's the workflow for you?
Well, I mean, it's thank you. It's there is no hard and fast rule, I'm afraid. It comes from knowledge of the genes themselves. Say, for example, I'll give you another example. The gene that encodes for guanylate cyclase 2D, okay, or juicy 2D for the short way of saying. There is only a hot spot for dominant mutations in exon 13, and this is the site of interaction. And that's why when a trainee comes to my clinic, I always ask them to please review your phototransduction cascade, because this is the key for so many things. Because if I give you a snippet from here and snippet from there, you'll get completely lost. If I tell you the cascade as a story, then you can think about, okay, what I should expect from this particular gene. What would happen? Back to the same gene. So exon 13 encodes for a particular domain in the protein that interacts with guanylate cyclase associated protein, GCAP. And therefore, missense, and not loss of function, missense changes in this particular region can alter the interaction, and then it can give you autosomal dominant cone rod dystrophy. Anything else in heterozygous state doesn't cause much. And therefore, if the lab itself doesn't really know about this particular domain in the protein, they might just mislead the clinician saying, your patient has got a heterozygous variant, and it is a cause of autosomal dominant cone rod dystrophy, and it explains the phenotype. So then familiarity with the genes, familiarity with the process. I don't want everybody to read about all the genes that exist that causes retinopathy. Some of the genes even we don't know how they work or how. But at least the common ones. If you find something fishy, don't get misled by what the lab tells you. If the lab says it probably explains the phenotype, just ignore it. Think about, okay, is it pathogenic? Has it been published? If it's pathogenic and published, then just check the papers. Because if the paper is a large population series, like containing like 100 exomes or something that, kind of at a table in the supplement with like all sorts of things, then probably most of these patients have not been phenotyped properly. And then you take it with a grain of salt. I'm not really sure. But if it has been, say, for example, some of the labs, they actually stick to the criteria. So the variant has been classified as pathogenic based on at least 3 publications, or 3 instances of unrelated, completely unrelated patients having the same phenotype. So that might be helpful. Sometimes you can see variant of uncertain significance, and then, as I said, you can correlate it with something else. Or if it happens in several families completely unrelated, and then you come across it, still it's a variant of uncertain significance, but it adds more weight. If you know about RP1L1, if you know about which exon, and that's why they, it's very simple for you, because if the lab says in exon 1 or 2 or whatever, then you can check in sample, where is this exon? Is it at the end? Is it in the penultimate exon or right in the middle? So having a bit of familiarity with the genes, the mechanism, which genes, which domains of the gene cause dominant or recessive, then you might be able to, there is always like there are the cases that you can get wrong. But at least having this basic knowledge will help you to navigate much easier, and then put a question mark on the cases that don't really add much or make much sense. And then you always have the discovery. So once you discover and you publish something, then please make sure that it's added to the database, because once the paper is published, there is no way you can go back and check the phenotypes of those patients. And that makes everybody's life difficult, because if this variant has been found again in your in your hospital, and you never know whether this patient was included in the paper or not, then you don't know it's a new case that you should actually, it adds evidence to what has been published, or it's actually the same case all over again, just being seen in your clinic rather than somebody else's. There is no easy way, I'm afraid.
Great. Again, thank you, Dr. Rola, for the explanation and the cases, and I think we can adjourn today's grand round. Thank you.